Hi. Whoa, geez, that was loud. Sorry. I think we're all ready if someone wants to shut the door. Thanks, boss. Right, so welcome to the evolution of treatment in hemophilia. This is Pratima Chowdary, sorry. Pratima is co-center director for the Hemophilia Center and specializes in the management of adult patients with hemophilia and related bleeding disorders. She's also the coagulation lead for HSL London and serves as a treasurer for the United Kingdom Haemophilia Center Doctors Organization. She has been a consultant hematologist for over 10 years and is the lead for the adult hemophilia multidisciplinary team. Her major research interests include personalized management, musculoskeletal outcomes, and lab assays for monitoring the replacement therapy. She has been an investigator on multiple clinical trials of novel and extended half-life products in severe hemophilia. You've done a lot. Congratulations.
Thank you. Thanks very much for the extensive introduction. Thank you. I mean, I think it's quite nice to say good afternoon, everyone, rather than hello, everyone, because you don't truly know to who you're speaking across Zoom or Teams. It's a great pleasure to be here today, and I think, and to talk about the evolution of treatment in hemophilia. I think when I was asked to, I kind of looked at the topic 3 days back, and I thought this probably mirrors my career in the Hemophilia Center at the Royal Free. Just a little bit of an anecdote in the third year of my consultant career, I was quite worried. I went away and asked Professor Tadadam, who was the center director, Prof, the only thing I've been doing for the last 12 months is adjust the dose of factor rate between 15, 20, or 25, depending on what the patient wants to do. Am I looking at this for the next 10 to 15 years? And that was my biggest concern. And that is when the first factor 9 trial started, and since then we have not looked back. I think in the last 10 years, we have probably done something like 25 to 30 trials. It's a testimony to the patients at the center that they've actually willingly contributed to various trials and then have helped us understand some of these new medications, because when you participate in trials, you kind of learn the medication as we go along. And that has helped us contribute to various guidelines. But that has also helped us to kind of understand how better we personalize treatment. So a big thank you to all the patients at the Royal Free for patiently putting up with me for the last 15 years and kind of contributing to all the trials. So I think in terms of, these are my disclosures. I think my disclosures probably reflect all the trials that we have done at the Royal Free. So I think in terms of bleeding disorders, I think we would say that bleeding disorders are a paradigm for monogenic disorders. And I think in terms of what are the treatment strategies that are available for monogenic disorders is what we kind of think about in terms of hemophilia. The first is, we would say, protein replacement therapy. That has been the standard of care until about 2 years ago for hemophilia. And in this, what you essentially try and do is you identify the missing protein in a monogenic disorder, and you try and replace and give it back to the patient. It's only possible if the protein is in the extracellular milieu. It's outside the cell. If the protein is within the cell, this does not work. But in hemophilia, it has worked, and that has been the standard of care. In many monogenic disorders, the standard of care is metabolic manipulation. What we're essentially saying is if something is missing, you try and manipulate it through different mechanisms, either through diet or through different drugs, but you try and restore what we consider as a normal physiological function. And that has been like, I'm not sure how many of you all have heard about phenylketonuria. That is considered to be the typical monogenic disorder. You change the diet and the patient gets better. And metabolic manipulation in hemophilia has, many of you all know about emicizumab. So that has become the kind of, it's come 30 years late in terms of metabolic manipulation, but we're here. And I think that is an area where we have seen an explosion in terms of clinical trials, and that is related to our understanding of normal coagulation. And finally, we have gene therapy. Gene therapy is the holy grail for all monogenic disorders. You're essentially trying to replace the missing gene, or sometimes modify the existing gene to kind of replace the normal function. And I think Obviously, it's very exciting because there's potential for long-term cure, and there's also potential, even if you don't cure, or we call as a remission from the disease phenotype. I mean, I think there are more than 10 trials of gene therapy in hemophilia A and B at the last time, but I think they keep adding on. The reason we have so many trials of gene therapy in hemophilia A and B is, again, it is the paradigm for monogenic disorders. If you have even about 2 to 5% of factor 8 or 9, we know that we can kind of get on the top of the bleeding phenomenon. And typically, they start in hemophilia, and then they go on to the other monogenic disorders. So I think we will continue to see further trials in this area from new sponsors. So we've kind of said that protein replacement therapy has been the standard for the last almost about 30 to 40 years. What about the successes and shortcomings? What have we actually gained from the protein replacement therapy? We can do it, as we've said, with standard half-life factor 8 or extended half-life factor 8. But I think the biggest gain we've had is the prophylaxis with standard has become the standard of care. And that is what has been responsible for decrease in fatal bleeding. A hemophilia patient in the UK now has a lifespan which is almost approaching that of the normal population. And I think it also decreases the number of spontaneous bleeds, it decreases the joint bleeds and joint damage, it decreases hospital admissions and improves patient outcomes and quality of life. And these are the things that has actually been kind of, in the US, they had to demonstrate this in a clinical trial before the insurance would agree to pay for prophylaxis. But within the UK, this has been almost been the standard for the last 25 years. In terms of the treatment regimens, many of y'all might have had a prescriptive regimen where your clinician would have set the dose and the frequency, or sometimes people would have agreed and adjusted the dose and frequency, depending upon the individual needs of the patient. But what about the shortcomings? One of the things is the personalized prophylaxis. You go to any conference, and even myself, we've all said personalized prophylaxis is the way to go forward. But the challenge of personalized prophylaxis is it is resource intensive. It requires time and commitment, not just from the clinician, from the patient as well. And that is a big thing, and I think that is, and we find that that is quite challenging. And then sometimes it might require a pharmacokinetic analysis where you give a dose of the drug and see how long the drug lasts in the individual patient. And I'm equally guilty. Many clinicians are guilty. We have given complex regimens to patients, and then surprise, lo and behold, they have not been implemented 6 months down the line. So I think these are the things that we find that the burden of treatment can be huge. And the intravenous infusions itself, they can result in peaks and troughs. They can be time consuming. I mean, I think I remember having a conversation with a patient who used to go away to work at 7 o'clock. He says, I don't have 5 minutes in the morning at 6 o'clock to do an infusion. And that's when you kind of start thinking, actually, this is something that needs to be accommodated for within the day-to-day activities. The other issues we have is the inhibitors to factor 8 or 9, which makes the treatment ineffective. And also, as a community, we have not truly agreed what is the consensus, what is the outcome we want. So if I said to my colleagues, I want 0 ABR as an outcome, then I'll straight away have 5 voices saying, well, we are not so sure about that. So I think that we've not had that kind of consensus saying, what are we aspiring, or what are we going to goal set for our individual patients? So within this context, what have we done? What have we achieved in the last 10 years? I think in the last 10 years, we've had the first extended half-life factor 8 and 9 licensed. We've had emicizumab license, which is what we would call as a non-factor therapy, but we also had the publication of the first successful clinical trial of gene therapy. I mean, that is what we have seen in the last 10 years. To me, that is tremendous progress. Remember, in my 3rd year of my consultant career, I was quite concerned that there was just 1 factor 8 and 1 factor 9. The only thing I could change was the brand, but no real difference other than maybe increase the dose if the commissioners would allow. From there, we've kind of come to a place where we now have got about 3 new choices and a variety of brands. What are we looking at in the next 5 years? These are the new drugs that are going to be licensed in the next 5 years. If you look at non-factor therapies, we have something called as anti-tissue factor pathway inhibitor. We've got 2 Pfizer and Novo Nordisk trialing in this area with this new product. We've got fitusiran. This is a drug that decreases antithrombin. We've got serpin-PC that also tries and normalizes the coagulation. And then we have more emicizumab-like molecules. So we've got second generation emicizumab. We've got other competitors trying to come up with emicizumab-like molecules. Then we have got a modified factor VIII, which is called as BIV001. This is what we call as the ultra-long-acting factor VIII. And then we have gene therapy. We have gene therapy being successfully piloted in Hemophilia A, in Hemophilia B, and now we've got clinical trials in a special population. And I expect all of these to be licensed in the next 5 years, because a lot of them are now what we call as phase 3 studies. They're in the final stages. They will undergo regulatory submission in the next 2 years. So we are expecting them to be available for clinical use if commissioned in the next 5 years. So within this context, I think I'm just going to try and underline some of the principles why there has been a big kind of explosion in the non-factor therapies. What we've understood is that thrombin generation is critical for clot formation, but the restoration of thrombin is more than adequate for hemostasis. So let's just kind of look at this in terms of, I mean, I think typically, as all of you all know, in terms of coagulation, we have got platelets and we've got clotting factors, and they interact together and form thrombin. We call thrombin as the central conductor or the critical enzyme of coagulation. This thrombin then works on platelets and fibrinogen and forms a blood clot. So this clot is a scanning electron micrograph. So these lavender blobs, these are the platelets. These green threads or strands is the fibrin strands, and the red ones are the trapped red cells. This is how a clot looks. The clot is agnostic in terms of how the thrombin is generated. It does not particularly care what happens upstream. If there's enough thrombin to work on platelets and fibrinogen, you will have a clot. So having understood this, what people have done is try and manipulate this part of the pathway to make sure that thrombin generation is adequate. So I think this is what a typical, I think thrombin generation is regulated. It is heavily regulated in terms of there are several things that would increase thrombin generation, and there are several proteins that kind of try and control and make sure that thrombin generation is regulated. It means only enough amount is formed and not too much, because if you have too much thrombin generation, you end up having thrombosis. So what we know from hemophilia is that if you do not have enough factor VIII and 9, then your thrombin generation is impaired, and that results in bleeding tendency. So here you have your procoagulants. These are your factor VIII and 9, which are decreased, but here you have anticoagulants. If you have too much of your anticoagulants, which are trying to regulate your what we call as the pro-clotting factors, then you have your hemophilia, or you have a bleeding tendency. So what we're essentially trying to do is restore the balance. And restoring the balance, I think as we've said, the way the thrombin generation, the clot formation is agnostic to how thrombin is generated. If enough thrombin is generated, it can form a clot. This is just not to confuse you all, just to kind of give you an illustration in terms of where the non-factor therapies are. There are 3 main enzymes in the coagulation cascade that result in thrombin formation. So this is where you have in hemophilia A or B, the factor VIII, I think, is just not visible here. But with factor VIII or 9, if you're missing, you have hemophilia A or B. So here you have emicizumab, which is an antibody that is bridging factor 9 and 10. It's just doing the job of factor VIII. It's doing it in a different way, but it is able to do the job. Again, over here, what I'm demonstrating here is the 3, what we call as the natural inhibitors. They inhibit the coagulation to make sure only enough thrombin is generated. Because the natural inhibitors are in normal quantities in patients with hemophilia A and B, by decreasing the amount of natural inhibitors, the little thrombin that is generated would be enough to form a blood clot. So basically what you're trying to do is knock out the natural inhibitors. So therefore, the amount of thrombin that is generated It may not be normal, but enough amount of thrombin is generated to form a blood clot. And what you've seen is, I think we've got anti-TFPI. This is one that knocks out a tissue factor pathway inhibitor. We then have got fitusiran that decreases the amount of antithrombin that is produced. And then we've got SERPIN-PC inhibitor that actually knocks out the inhibition of activated protein C. And that is the reason why you have all of this. And this is related to our increased understanding of the normal coagulation of the last 10 to 15 years. We've had a better and better understanding, but we've also looked at patients where there has been antithrombin deficiency, where they've had tissue factor pathway inhibitor abnormalities, and then I think that's how we ended up with all these trials. So currently of these molecules, only emicizumab is licensed, but we have got several. The Mymate is coming from Novo Nordisk. They're running a phase 1-2 study that works exactly like emicizumab. We've got fitusiran, and that actually decreases the amount of antithrombin. We've got concizumab and marcizumab inhibiting the tissue factor pathway inhibitor. The Bayer study was stopped because they had thrombotic events. The SERPIN-PC is just in phase 1-2 studies that were developed. I think they were run in Eastern Europe, and this one is just in the preclinical. This is just to demonstrate in terms of the principles where we said how does the thrombin generation kind of improve in relation to suppressing the natural inhibitors. So I think if you focus on the graph on the right side, what you can see over here is if you decrease the antithrombin to only a little, by about 25%, then there's no real impact on the amount of thrombin generation. This represents the healthy volunteers, but if you decrease the antithrombin to more than 75% of the normal, what you can see is the thrombin generation is actually almost overlapping with normal. So we're unlikely to kind of overdo it, but we're probably going to go into the normal range or just below normal range to kind of prevent bleeding tendency, which we see in severe hemophilia patients. Similarly, this is the anti-TFPI or the concizumab, which inhibits the tissue factor pathway inhibitor. What you can see is as the concizumab level increases, the amount of thrombin generation, as we say, the peak thrombin generation kind of continues to increase, but there is a plateau effect at certain concentration of concizumab. So this is currently in phase 3 studies, and I think we would expect the results sometime next year. So I think the reason I've kind of gone through the entire thrombin generation is to kind of give a little bit of a background in terms of why do we have thrombotic events with non-factor therapies. Remember I said that thrombin generation is heavily regulated. And because there are checks and balances, and what we're essentially doing is we're removing some of the checks. Whilst most of the patients may not be affected, but I think just going to the normal amount of thrombin generation and are perfectly safe, there is some concern that there may be an excess amount of thrombotic events. And what we've seen is that all the trials have shown thrombotic events. We've seen thrombotic events with the fitusiran, we've seen it with concizumab, and we've also seen with emicizumab. But as the thrombotic events have developed, we are learning. We're learning what is it that we need to do to make sure these things don't happen. So for example, with the emicizumab and thrombosis, we've learned that it was because of a drug-drug interaction. This was seen in the patient with the inhibitor trial, where patients with emicizumab and inhibitor patients having emicizumab, when they had a bleed, they were treated either with NOVA7 or FIBA. And the thrombotic events were only seen in the patients who received FIBA. I think subsequent investigations showed that it was a drug-drug interaction between emicizumab and FIBA. This is something we just did not conceptualize when the study was started. So, and then I think subsequently they looked back into the study, and then there's a lot of a big post-marketing surveillance to understand if there was any interaction with NOVA7. No thrombotic events have been reported with emicizumab and NOVA7. And now the standard of care has changed. We do not give FIBA to patients to keep at home. Sometimes if they don't respond to NOVA7, the recommendation is they come in, we admit, we give a FIBA under supervision rather than giving it at home. Similarly, I think with fitusiran as well, they had the first thrombotic event in 2017. when a young man died, this was in Eastern Europe, because of a misdiagnosis. They missed a thrombotic event on a scan and diagnosed it as a bleed, and the patient went on to receive factor VIII. And that was quite unfortunate. But what we again realized is that there is a drug-drug interaction between, if you knock down your antithrombin and you give normal levels, a normal amount of factor VIII and IX, you have more than an additive effect. You have a bit of a synergistic effect. You have too much amount of thrombin that is floating around, and that has resulted in the thrombotic event. And what they've essentially recommended is that you use lower doses of factor VIII and IX and bypass agents if a patient on fitusiran develops a thrombosis. And then I think they had a further event in 2020, and because of this, there was an entire review in terms of all the data. And what it showed is that if you have an antithrombin level that is less than 10%, then there is a potential for you to have thrombosis. And again, I think because of this, there is now a recommendation that once you go on to the trial, you receive fitusiran, if your antithrombin level is less than 10%, you come off the trial. You're only allowed in the trial if you're able to maintain an antithrombin level between 15 to, I think the upper limit of normal was 35. So if you're able to run between 15 and 35, you're allowed to stay in the trial. But if you go beyond or low, then you're not allowed to stay in the trial. Again, we've had thrombotic events with the anti-TFPI therapeutic molecules. With the Bayer anti-TFPI, 2 arterial events and 1 venous event was seen. Again, the data was reviewed and no clear explanation was found as to why the patients developed a thrombotic event. We knew it was because of the drug, but we couldn't identify a drug-drug interaction, and because of which Bayer has essentially stopped the trial. And then we have consuzumab. Again, they had 3 thrombotic events. All the 3 events were seen in the patients with interaction with factor VIII and consuzumab. Again, with the risk mitigation, the trial restarted this year. The recommendation is use lower doses of factor VIII and factor IX, and the investigator must confirm the bleed dose. And then now coming on to more factor VIII. So I think there's been a lot of excitement in terms of the BIV001, or what we call as the ultra long-acting factor VIII. So this is what I would call as an engineered molecule. I think they must have put 10 scientists in their room and said, come up with a factor VIII that beats all competition. So I think when we kind of saw this was presented about 3 years back, we were all a bit dubious. This factor VIII, as we know, is a large protein. They've made it larger. They've added in 2 chains called as X10 to increase the half-life. This is essentially Elocta, so you have half a bit of an immunoglobulin molecule. You added a little bit of a von Willebrand factor. Essentially, we just look big. I always call it as the obese factor VIII. But saying that, it's in clinical trials. It's in phase 3 trials, and the phase 1 data has been published in New England Journal of Medicine. And what essentially they showed is that it's about 4-fold prolongation. So we are truly looking at a once-a-week prophylaxis with factor VIII, with troughs running anything between 6 to 12%. And I think that, again, this is also in phase 3. The results probably will come into next year, and the phase 1 data shows that the drug was effective, and there was no suggestion that there was any excess amount of inhibitor formation, because that is the biggest concern. It's fine to modify the molecule, but the concern with factor VIII molecule is there a risk that you will have an excess amount of inhibitor formation? So I think in terms of more modified factors, that is where we are in terms of modified factor VIII. I think there is, again, several other trials or preclinical trials that are happening where people want to give factor IX orally, factor VIII orally. So I think these are all kind of fancy things that we have seen in terms of preclinical data. I haven't seen a phase 1 data, so if I haven't seen phase 1, I've not included in this presentation. I think lastly, we'll just kind of look at gene therapy. I think with gene therapy, the concern for all trials is about the safety. It's not just about the allergic reactions and the transaminitis. The transaminitis is of interest mainly because it results in loss of expression. You can lose factor 8 or 9 expression if there is a little bit of a liver inflammation. The long-term risks are mainly in terms of thrombosis. What level of factor 8 or 9 is safe? And also, is there a potential risk for cancer? And in terms of efficacy, the one that we all want to know is what is the level that an individual patient will achieve and how long will it actually last? Not just the patients and the clinicians, even the payers want to know. If they're going to invest the money in gene therapy, that is something that everybody wants to know, is in terms of what is the predictability and durability of expression. Again, there's a lot, I think I'm not going to go through in terms of what are the benefits. So in terms of the gene therapy, most of hemophilia gene therapy has been based on what we call as adeno-associated virus. I think the reason this has been popular is that not just hemophilia. If you look at the clinicaltrial.gov website, there's something like 200 gene therapy programs with adeno-associated virus. The reason is this is a virus, it's quite small, it's a single-stranded DNA virus. You can just strip this and put in the gene of interest and put in a promoter. It's a very, very simple gene, and because of which our hope is it doesn't cause too much mischief. So, and I think the other one is of interest is the fact that it is actually episomal. What we mean by episomal is, if you can see here, this is the nucleus, this is your chromosomes. It just sits outside the chromosomes. It sits within the nucleus, but it's actually outside the chromosomes. So it does not integrate into the chromosomes. And that is a reason why we believe that the AAV-based gene therapies are safer. The amount of integration events we believe is less than 0.1%. So they do happen. But also, there's a lot of data of AAV from what we call as community transmission. So if you kind of check a group of patients, I think when you're about 20s, only 10% have got AAV infection. But by the time you've come to 60 or 70, 40% of the normal population would have had AAV infection. So we have something in the nature to look around to say, how worried should we be about this virus? Again, I think there are 2 studies that have presented their phase 3 data. This is the Unicure study, which is now being picked up by CSL Behring. And what they've essentially said is that in terms of their levels at 26 weeks, they had a level of 32% in patients with antibodies to AAV, and they had a level of 41% in patients without antibodies to AAV. I think if your levels go into the mild hemophilia range, not surprisingly, the bleed stopped and the consumption decreased. And I think they've said that the amount of inflammation of the liver that they have seen in their study was quite little, and very few patients required steroids. These are the kind of hemophilia B gene therapy trials that are ongoing. Again, I think several of them are in phase 3, and we can expect some results next year or 2022 or 23. And then we have the other phase 3 trial that was published, and I think Mike, I'm sure half of you all at least follow Professor Macris on Twitter. I think it is quite handy to get all the results kind of up to date, your own personalized results. And I think this was the one that was the BioMarin phase 3 study. And what they've essentially shown is, even their phase 3 study showed you can get a very good level by around 26 weeks, which is where you get your peak level, but there is a loss of expression with time. And I think that is something, and this is the 17 patients who had a 2-year follow-up, and you see, I think the axis has changed. I think there is loss of expression with time. Essentially it mimics what they've shown in the phase 1 data, whereas this loss of expression with time has not been seen with hemophilia B as much as it has been with hemophilia A. We don't truly understand why there is a loss of expression with time with hemophilia A. One of the suggestions is that the factor VIII protein is a much larger protein, and whether that is causing some of the issues. Again, I think they've said that, infusion reactions were quite minimal. The most common adverse event was an elevated ALT. And in none of these studies, the ALT elevation is of a level that is of concerning clinically. The ALT elevation in gene therapy is of interest because it signals that the liver inflammation is going to result in loss of expression, which is the reason that patients in most of the gene therapy trials are intensely monitored for transaminitis or liver inflammation so that we can start treatment earlier than later. So I think the question is, now we've already got 4 new products in the last 10 years. We're going to add 5 or 6 more products. I think the question then is, truly we have quite a bit of choice. So I think therein lies the personalization of care. I think we've talked about it quite a bit for the last 10 years, but probably now is truly where we'll be able to implement it. I think when we think about personalization of care, it's kind of helpful to think in terms of what are the domains of hemophilia care? Where is it that we can make an impact? I think we can think in terms of bleed prevention or control. This is where all the products have been, all the innovation has been in terms of how can we stop the patient's bleeding. And that has an influence directly on terms of the patient experience because we allow them to sports, leisure, job opportunities, and relationships. That has a direct influence. But the one thing that we've not been able to influence is the joint damage. Joint damage is pretty much irreversible at this point in time, and pain is a major issue because of joint damage, and that in turn has limitation on activity and exercise. So these are the 3 kind of domains, and it's understanding how we can influence the 3 domains to help in terms of personalization of care. I think the other thing that is also coming through is the concept of workload and capacity on behalf of the patient. I think this is coming through across all of chronic care, that what essentially we are saying is, or the literature is saying, that hospitals and clinicians can be unreasonable, expecting a lot from patients. I think in terms of workload, it's just not the treatment burden, it's the disease burden, it's the professional commitments, it's the personal commitments. So all of these add to what we call as the patient workload. And the capacity is to do with in terms of the ability to handle work, all of them, personal, professional, health, but also access to time, finances, and support. And I think that this has resulted is in the concept of what we call as rationalized non-adherence. It isn't that the patients are not adherent. It's just that I've had that many a time. We've had the discussion and then they kind of say to me 6 months, it just was not possible. So I think that is what it's kind of now, it's been acknowledged and kind of making its way in the literature, that this is not that the patient is not adherent, that the prescription that was given does not fit in with the patient's life, and therefore it is an active decision on the part of the patient to say this is just not possible. And I think we just have to acknowledge, and this is something that we have to acknowledge as clinicians, and then plan a regimen that actually suits the needs of the patients. So I think in terms of management of hemophilia, this is probably more of a personal opinion. I feel that 0 ABR is the minimum of standard of care. It kind of tells you that we've got the hemophilia under control. It doesn't tell you that that is what is the highest we want to achieve. It is the minimum standard of care. I think we also, as a group, we have not defined treatment failures because with the non-factor therapies, there is no scope for increasing the dose. If you're on a particular dose, you've either responded or you have not responded. We have to identify what does it mean to be a non-response. Who is it who has not responded? Because if you don't define who has not responded, you can't switch therapies. If you have access to 7 or 8 therapies, we do need to start thinking about who are the patients we're going to switch therapies. We also need to have better understanding of how does patient-focused outcomes look like. I think there's been a lot of emphasis saying we have to kind of have patient-focused outcomes, but we don't really have validated tools that can tell us over a period of time that this is helpful in clinical care. And I think the new mantra will be the right treatment for the right patient. And that will be very much dependent upon the risk-benefit analysis. How much of a bleed protection does the person require? A younger person who is active in sports will require more protection than somebody who is in a sedentary job. There is an element of patient choice. What are the outcomes that are desired, but also the treatment-related complications. We have to take into account, we need to have those discussions. So thrombosis is a risk, but it is a very minimal risk. But it's important, but that needs to enter into the discussions. And patients have different perceptions of risk. And I think that depends in terms of the benefits. Acceptance of risk is directly, at least in my clinical practice, I've seen is dictated by the amount of benefit. If you have no benefit but taking on risk, I don't think I've had anybody accept that kind of treatment. Then I think we're probably truly coming into the era of informed and shared decision making in terms of explaining and empowering patients. And I think both need to participate in this, about the desired outcomes and also of the treatment options that are available for a particular condition. So I think in terms of concluding, what I would say is that the pace of change is accelerated with an explosion of choices, and that is going to be quite challenging for all of us. For the first time, we may actually look towards the commissioner saying, or maybe we should restrict choice, but that is not a place we want to be. So I think we need to be a little bit more savvy of how we're going to use the choices for the best outcomes. A one-size-fits-all prophylactic strategy is no longer appropriate. That is where we were about 15 years ago when I started my consultant career, and that is from where we want to move away from. The treatment burden is difficult to quantify, and it's quite easy to underestimate. And I think that is something that I have learned repeatedly. It's better to ask the patients what they think is acceptable than kind of assume what is acceptable. And the other more important thing is there's no virtual reality for treatment improvements. I think I say this because I've had several discussions, sometimes with patients as well. I don't want to change. There isn't a reluctance to change because there's anxiety about the new product, but there's also anxiety about the potential benefit. And it's quite difficult to explain how it will look like. And sometimes we've ended up doing what we call as a therapeutic trials. We've said, use it for 3 or 6 months and say, if you don't like it, we go back to where we were. And that is the biggest challenge for most clinicians in terms of how do you translate the benefits that you see in clinical trials in terms of the patients, how do we explain the potential benefit? And I think over here, again, as I mentioned before, shared decision making is increasingly crucial for obtaining good outcomes for our patients. Thank you for your attention.
Thank you very much. We have about 6 minutes or so for questions. So we have a couple from online, but does anyone in the room have any questions you would like to pose? Okay then, more time for online. Bear with me for a moment. I should probably have 2 mics here.
I'll take it.
Yeah.
Thank you.
Is that, oh, good it is, that's exciting. So the first question we have is, I'll read it out. Firstly, congratulations, Pratima, on recently being appointed the new chair of the UK Hcdo.
Thank you.
People living with Haemophilia A have been forcibly switched from standard or FC fusion EHL to PEG EHL because of the tender. Please can you clarify if nationally patients and their families do have a choice over product, or if some centers are limiting patient autonomy because of product cost and center budget?
Will probably is the right person to answer, but I think it is, in some ways, it is slightly center dependent in terms of the local commissioners. So I can only say within London, we have not switched patients from Elocta to another pegylated long-acting factor VIII. We've mainly concentrated on the patients who have been on standard factor VIII, moving them to the EHL. I think patients do have a choice, yeah. So I think in a simple answer, yes, they do.
Wonderful. Here's some more for you. Some companies are submitting a regulatory application for their gene therapies next year, followed by HTA for reimbursement. What is the likelihood of gene therapy being approved for Haemophilia A and B on the NHS in the UK? And do you see this being limited to a particular cohort of the community, or will it be made available to everyone that's eligible based on non-clinical need.
I think with gene therapy for monogenic disorders, this will be the first one, I think, or probably the second one. So I think at the moment, my understanding is I've attended a meeting where NICE is looking at a different form of assessment. I think typically NICE would do a quality assessment, but now they are trying to look at a different assessment to reconcile what the manufacturers thinks is the price of gene therapy and what NICE thinks may be an appropriate price. I suspect it will be available. I think the question is, when will it be available? I doubt it will be next year. I think it'll probably be 2023. And I suspect we will end up on a CAR T cell type of a way of delivering care, where only some centers will be providing the infusion, not all centers. But I also suspect we will end up with some X number of patients per year. I mean, I think if not, I think it's mainly to do with the budget. And that is a speculation, so I have no true kind of feel in terms of how they would be going ahead. But saying that this will be probably the first one that NICE and NHS England will need to address, because this is just first of many gene therapies coming from monogenic disorders. So I suspect there will be a little bit more of time and thought given in terms of how to manage this, because once we've done hemophilia, we essentially set the standard for the rest of the monogenic disorders.
Excellent. Last one. How can the UK Hcdo and patient community work closer together to make product decision processes and management of patient data? By management of patient data, I mean what is sold for industry use, albeit anonymized, for example, from HemTrack, and to make it more transparent to support informed decision making. Sorry, that was a big... Should I do it
Yes,
again?
let's start, okay. That was 2 questions.
So it is, because there was an addendum to it. So when we speak about management of patient data, we mean what's sold for industry.
Yeah.
So how can the UK Hcdo and patient community work closer together to make product decisions and management of data more transparent to support informed decision making? I should have done it that way first.
Yeah. I'm going to answer it in a very generic fashion in terms of how can we use UK Hcdo data for improved patient care. One of the things that we have used the UK Hcdo data for particularly in the last 3 years is during the tender. When the emicizumab switch happened, I think we went back, I think Paul was there on the group, where we looked at the number of patients with inhibitors, and then we kind of costed what was their annual cost per year for the entire cohort, and we kind of gave the data to NHS England. And that helped them in the negotiation with the manufacturers in terms of what we think is an appropriate price for emicizumab. So I think that is where we have kind of used the UK Hcdo data quite effectively. In terms of individualization of care and shared decision making, I think it's a little bit more challenging, because at the moment, patients put in data, but they don't actually see their data in the context of other people. So I think it's more of understanding what I would call as benchmarking. It's not just about knowing my own performance within, let's say, when we have our 360-degree evaluations, we want to know where we are standing in reference to others. And sometimes if I'm standing with the middle of the cohort, I'm not too worried. But if I am standing a little bit out with consensus, then that is something that I would like to kind of change. So I think that is a larger piece of work, understanding how we provide data. Because at the moment, the data is not kind of summarized in such a fashion that people can see and understand. So if there is a question, then we analyze the data appropriate to the question. But I think at the moment, we do need to look at how can we analyze the data that is friendly for regular use. Yes, I agree.
Excellent. That was the last question I had from online. So unless anyone else in the room has one final question. You're online, though, remember?
Oh, sorry. Apologies. Just on that similar theme about sharing data, and these are all novel therapies, which very interesting presentation, but how does your typical man or woman on the street keep themselves up to date with where things are going to then be that informed patient to be able to have the right conversation with their clinician?
I mean, I think partly we kind of hope that Hemophilia Society would play a part in that in terms of educating, because that is one source of information. And then the clinician responsible for the care of the patient becomes another source. But for the clinician who's taking care of the patient, typically the UK Hcdo will let people know, I think, through what we call as the clinical reference groups and also the procurement subcommittee saying, these are the drugs that are there, will come in license in 2 to 3 years. And then we need to kind of think about how we might want to use it. So I think this is an annual exercise, nothing related to hemophilia, but every year we are asked to do what is called as a horizon scan. Come April, I think around February time, we get a letter from the pharmacist saying, can you do a horizon scan and tell us what you think will come into practice in the next 1 to 2 years? And that data is fed from most trusts and then fed nationally. And I think we would then do within individual kind of specialities as well, we would let the commissioners know. For example, with all of these medications, the commissioners are aware that these medications are out there. And then as soon as the publication comes, we keep an eye on when the license is coming through. Because they can only procure what is licensed. So I think we keep an eye on all of that.
Thank you.
Thank you.
And thank you very much.
Thanks a lot.
Wonderful.
Thank you.